Well, welcome everybody to the second meeting of the MAC. Today we're gonna, this is gonna act as a public forum for some of our speakers. So there will be, after they do their presentation, there will be a moment we're gonna allow for public comment as well. I want to start by, we're going to vote on the bylaws, and then Jennifer and Cosina will present on TEFRA and our home, and then Elizabeth is going to go over the Arkansas community engagement requirements and the budget bill analysis, and then we'll kind of talk about some new ways we've thought about communication with the MCVC to kind of help streamline that a little bit, as well as come up with agenda items for next meeting. All right, with that, has everyone had a chance to review the bylaws? Okay, so I would like a motion to approve. I don't think you can. We approve the bylaws. Okay, do I have a second? Okay, awesome. The only thing that will change, we'll put today's date in that blank spot. Okay, well, with that, I will turn it over to Jennifer to go over TEFRA. All in favor? Sorry. Okay, thanks.
Good afternoon, everyone. My name is Kashina Lang, and I'll be presenting for TEFRA today. TEFRA, the purpose of this is for us to have a public forum. TEFRA is the Tax, Equity, and Fiscal Responsibility Act. It operates as a demonstration waiver. Federal regulations do require that we do an annual public forum to solicit comments on the progress of the program. The public will have an opportunity to provide any comments and ask any questions. We are required, when we submit our annual report, to give a summary of how the forum went. TEFRA is a Medicaid program that helps families with young children under the age of 19 who have disabilities, and they receive care in their homes, rather than them going into an institution. The program, can't hear me? Thank you. The program can help pay the cost of medical expenses for children so that they are able to stay in their home as opposed to going into an institution. With the program, families will have to pay a premium. It's on a sliding scale basis, and it is dependent upon the family's income, not the child's income, but the parent's income. There are some things that we look at with eligibility for TEFRA. There's a financial eligibility criteria that has to be met. That criteria is based on the child's income. They also have to meet a disability criteria. Either they have a disability that has been established through Social Security Administration. If not, then they will go through our MRT process. MRT will make that determination on whether they qualify for a disability. That qualification that they're looking at is based on Social Security Administration's requirements to meet a disability. Once we go through the process, they also have to meet medical necessity and the appropriateness of care. When we're looking at their financial requirement in determining eligibility, it is based on the child's income. And that child's income cannot be 3 times more than the current SSI SPA amount. That current amount times is, I believe it's $967, so $2,901 a month is the income limit that they have to meet. We also look at resources. The child's income, the child's resources cannot exceed $2,000. The only time we're looking at the parent's income is when we're determining what their monthly premium will be. Again, as I stated before, the child has to meet Social Security's administration's definition of being disabled. If they have received SSI within 1 year prior to applying for TEFRA, and they continue to have a disability, but they lose eligibility based on the parent's income, then they could still be eligible for the TEFRA program. Again, if that disability has not been established through Social Security Administration, they would go through our MRT process. That's our medical review team. The medical review team will get access. We will require the parents to complete a social report. They will sign a release for DHS to get all medical records. The MRT team then will review all of those medical records to determine if the child meets the definition of being disabled. They do have to have a medical condition that would cause them to be in an institution or put them at risk of going into an institution. Their medical necessity is also based on services that improve or maintain the child's health. We want to prevent the child from having condition from getting worse. After that child is determined to be disabled, then our TEFRA committee will then determine the appropriateness of medical services. They're going to determine what services that child needs. Again, our goal is to keep the child from having to go into an institution. The estimated cost of their care, it cannot exceed the cost of the care if they were in an institution. How do we determine TEFRA premiums? That TEFRA premium is going to be based on the parent or guardian's income. And how we look at that income is we look at their federal tax returns. If there are after applicable deductions, and we'll talk about the deductions, if they're at 150% of the federal poverty level for their household size, then they will have a premium to pay each month. Deductions that they can receive from their income is they'll get $600 per child. It has to be a biological child or adopted child. And that child does have to be listed on their federal income tax returns as a dependent. We will also deduct excess medical and dental expenses that is itemized on that tax return. How we look at the premium, the first thing we're going to look and see what's their income for their household size. Does it fall within that 150% of the federal poverty level? So once we determine their income, we'll then go to step 2, where we'll find their income. Let's say their income after deductions is $42,000. We're going to take that $42,000 multiplied by 1%, comes to $420 a month to get their $450 annually. To determine their monthly premium, we would divide that by 12. If my math is correct, that should be about $35 a month in premiums that they would have to pay. Last year in 2024, the program served more than 7,000 beneficiaries here in Arkansas. Each year we do a survey that is sent out to our TEFRA applicants, and it's a pretty lengthy survey, but one thing we look at is the quality of care, how they feel about the program. Right now we're doing pretty good in a lot of areas. 93% are happy with getting care quickly. Customer service is at 70%. Special therapies, they rank that about 90% are pretty satisfied with the special therapies that they're receiving. The TEFRA survey, the results are published each year if anybody's interested. We were recently approved for a new waiver that starts January of 2026. And with that came a few changes to the program. We are now required to have a good cause exception for families who are unable to pay their TEFRA premium. Of course, that's due to some type of emergency or some type of life-changing event. We're also looking at, currently right now, all of our TEFRA applicants do an annual renewal. We are looking at changing some of the applicants to do a renewal every 3 years as opposed to annually. For general information for TEFRA, how do you contact TEFRA if you have questions? For general information, you can contact AFMC at 1-855-372-1084. You can also call the Arkansas Medicaid Assistance Hotline. For TEFRA premium payments, anytime they have an issue or have a question about their payments, the billing invoices, anything related to their TEFRA premium, they can reach out to the TEFRA premium unit. And the number for the TEFRA premium unit is 1-866-239-9938. For application status, what's my eligibility? Have I been approved? Is my application still pending? They can contact their local DHS office if they needed to. We also have a link on the DHS website that gives them important telephone numbers for TEFRA. If they wanted to log into their account at accessarkansas.gov, they will also can receive updates about their application there. Again, for billing invoice questions about their premium, they would contact the TEFRA premium unit. They can either they can either visit the website or they can contact them at that number that's provided. Questions about medical claims. They can contact AFMC. Number there, 800-482-5431 or 800-432-8988. For questions outside of here or any questions you might have with TEFRA, you can contact myself. My email address is kashina.lang@dhs.arkansas.gov. You can also email Larry Ballard. If you want to send in something through mail, you can send it to the Division of Medical Services, 700 Main Street here in Little Rock. At this time, if anybody has any questions about the TEFRA program. Okay. Well, if nobody has any questions, then I'll turn it back over to Crystal. Thank you.
And now we'll hear from Jennifer on our home. Hey, good afternoon, everyone. So I'm Jennifer Dedman, and I work with the Our Home program, which is the Arkansas Health and Opportunity for Me program. And some of you may have heard of the program. I know that we've got at least one of our advisory panels here in the room. Anybody familiar with Our Home already? Okay, great, excellent. So this is also our public forum. Our home operates as a Section 1115 demonstration waiver. Federal waiver regulations require a post-award public forum to solicit comments, and that's what we're doing today. Public, outside of this meeting, just the public in general, also has an opportunity to provide comments. A forum summary is going to be included in our annual reports, which we will submit to CMS, and here's where we've got the forum materials available. In general, you'll just go to the DHS events page, and you should see a listing for the Medicaid Advisory Committee, Our Home, and TEFRA public forums. So to give you a little overview, Arkansas's Medicaid expansion program under the Federal Affordable Care Act is Our Home. Our Home, we took our expansion as an 1115 demonstration waiver, and Our Home serves adults between 19 and 64 years old who have a household income below 138% of the federal poverty line. It's established as a Medicaid waiver program to allow Arkansas to spend our Medicaid dollars to buy private insurance for our clients. We buy silver level plans.
The federal government pays 90% of the cost, and Arkansas pays 10%. In 2024, those expenditures totaled $1.8 billion for our home. Currently, our population looks like this. We've got about 222,000 people currently enrolled in our home. About 13.1% of Arkansas's non-elderly adults receive their health care coverage through our home. 54.4% of our home enrollees are women and 45.6% are men. About 67.6% are 45 years or younger. About 49% are below or equal to the 20% mark on the federal poverty line, and 16%, I think that sign's pointing the wrong way, are under 100%. So let's talk about renewal. Our home requires an annual renewal. To renew, people just have to look out for their Medicaid renewal form, which we will send over, fill it out, and send it back. Here's where you call if you have questions about your renewal. We've got a call center at 855-372-1084. You can also go to arkansas.gov/accessanywhere and submit a question, or we've also got local county offices that are ready to receive your questions. You can call or visit those. If a person has lost health care coverage because of missing requested information, they can still provide that information and their coverage will be reopened. They have 90 days after closing, if they qualified for our home, to go ahead and do that. The easiest way to get the needed information in is to go to access.arkansas.gov and sign into or create an account. And we'll revisit renewal here in a moment. So this is what our enrollment looks like. As I said a little bit earlier, we use Medicaid funds to buy plans. Our plans are through 2 insurance companies, each of whom have 3 QHPs. So these are our quality health plans. You'll see in the Blue Cross items, and in the Centene QHPs are in green. So about 12% are with Octave, 37% are with Arkansas Blue Cross Blue Shield, 10% with Health Advantage. And then over on the Centene side, we got 12% with Qual Choice Life and Health, 19% with QCA, and 10% with Ambetter. So that's our breakdown for our QHPs. Health plans are required to do certain things. They're required to provide incentives to their members or providers to encourage health improvement activities. They must submit annual quality assessment and performance improvement strategic plans. We have an upcoming advisory panel meeting in December, and the QHPs will be presenting their strategic plans during that meeting. They have to meet annual targets on quality of care measures, and if they don't meet those targets, DHS may assess penalties. We have some recent metrics available. They were part of our September panel meeting. You can find those on the DHS website, or feel free to contact me. I'd be happy to send out a report and information. We did have most of our metrics during September, but we have some more coming for our December meeting. So if anyone is attending the December meeting, you'll see our metrics, strategic plans, and targets and penalties. So here's our 2024 QHP results. These are the healthcare metrics that we discussed. These are only the ones that happened in September. We're still waiting on a couple for December. It's a high bar. You can see that all of our QHPs met use of pharmacotherapy for opioid use disorder, and most of them met follow-up within 30 days after hospitalization for mental illness. And then we have some mixed results. Most of our QHPs did not meet the items in orange, and none of our QHPs met the items in red. We are waiting to find out what our December results will be. If you tune into our panel meeting, you can find out how that goes. But that's the, let's see, I think those are the measures for breast cancer, diabetes, and behavioral health for December. So we're still missing some. We do have some upcoming program changes. Under the One Big Beautiful Bill Act, our home is preparing for the new work requirements under the Federal Reconciliation Budget Act. You're going to hear from Elizabeth about that a little bit later. The requirement's effective date is January 1st of 2027. Our home renewals, which currently happen annually, are going to happen every 6 months instead of annually, and that starts at the end of 2026, December 31st. We have more details coming in upcoming months, so stay tuned for that, and we'll communicate things as we know more. The Our Home waiver renewal is also coming up. It was initially set to end December 31st of 2026, but Act 774 of 2025 authorized an extension. So we have begun seeking renewal of our Home demonstration waiver, and we're working with CMS on that right now as well. Maternal Life 360 is a part of Our Home. And it's a program that's newer, and we're really proud of our progress here. The concept is DHS is contracting with hospitals to provide home visitation for women with high-risk pregnancies and assistance in addressing social determinants of health needs and enhancing life skills. The Maternal Life 360 home hospitals coordinate with the beneficiaries, medical providers, but medical services continue to be covered by the QHP or fee-for-service Medicaid, whichever is applicable there. Currently, we have one Maternal Life 360 home that's active. We initially got 12 letters of intent, of which we approved 9. We ended up with 6 applications. We currently have 4 provider agreements to serve a total of 245 beneficiaries every year. And currently we have 114 beneficiaries enrolled in a Maternal Life 360. Well, we certainly did as of August. There may be more by now. Here's what our service delivery and population looks like. Life 360 hospitals contract with an evidence-based home visiting provider to provide home visits. The home visiting program provides services to those with a high-risk pregnancy who live in a service area for up to 2 years after birth if they're in our home, or 1 year for other Medicaid beneficiaries. And our home beneficiaries can continue to receive services even if they disenroll. What you're seeing here are a variety of programs that they're working with. So we've got early Head Start, home-based. We've got Healthy Families, Parents as Teachers, Nurse Family Partnership, Early Head Start and Healthy Families, Parents as Teachers, and Healthy Families in the green. Nurse Family Partnership, and also Parents as Teachers in the pink. So you can see the areas where we have combined service area coverage. A lot of great partners there, really good programs. Mercy Northwest is our newest. We executed a startup agreement with Mercy in July of this year, and we've got a readiness visit coming up November the 10th, so they're getting moving. St. Bernard's Medical Center was our first. They opened their Life 360 in November of last year. They're in Jonesboro. They've referred a total of 97 beneficiaries to Jonesboro Urban Renewal and Housing Authority Parents as Teachers program, which started conducting home visits with all beneficiaries who have completed a program intake and linked those families to community resources, including nutrition, transportation, other resources through their local referral network. White River Health Medical Center started in January of 2025. Oh, I misspoke. We do have White River. In January of 2025, and they have River Health subcontract with the Batesville School District, which has a Parents as Teachers program to provide Life 360 services to up to 45 beneficiaries. And we have Baptist Health Medical Center of Little Rock and North Little Rock that are serving through their MEHOW program, the Maternal and Infant Health Outreach Worker Program, which is a new evidence-based home visiting program in Arkansas. The Little Rock program can currently serve 50 beneficiaries in Pulaski and Sling counties, and North Little Rock can serve also 50 beneficiaries in Pulaski and Faulkner counties. So their service area is 3 counties there. All right. If you have comments and questions, you can email them to me, or you can mail them to me at DHS, or you're free to express them during this public comment portion of this meeting. We'd be happy to hear from you and respond. And here's some additional contacts. Some of you may have worked before with Nell Smith on this program. She's still a potential contact, but if you've got questions, please send them to me. So do we have any comments or questions about our home? Yes, can I have your name, please? Amy.
My daughter is in our home.
We're going to bring you a microphone, Amy. Thank you.
Sorry, Jennifer.
No, not at all.
And I know that, and I was confused about, she got her she's Blue Cross.
Oh, okay.
So, but is there a dental component? Because I don't think there is. And if there is, how do you access that if you are on our home?
So dental is available if you're 19. So our home serves 19 or 20. Our home serves 19 to 64. For people who are 19 or 20 years old, there is a dental and vision component available. As far as how to access that, you can log it. So it's available through Access Arkansas, correct? You can log into your Access Arkansas account. Is that one potential way to access? If you don't currently have dental benefits and you'd like to apply for those?
You don't have to apply for them. They're covered through fee-for-service Medicaid, so
Okay.
you should have an underlying Medicaid card. How
Oh, no.
is your daughter, 19 or 20? She doesn't.
Okay.
It's only for 19.
It's only 19 or
so-
20, unfortunately, yeah.
Yes, under early periodic screening, diagnostics, and treatment, we have to provide dental and vision to 19 and 20-year-olds, but it's not an essential health benefit under the ACA. So it's not covered as part of the plan.
Thank you, Elizabeth. She knows everything. Any other questions or comments?
And I just have one more question.
Yes, absolutely, Amy.
From the QR code that you presented, I don't know where Mary is. I think she left. Mary left. Are we able to, for access, is that all links? So if she needed to upload something for her benefits, the same QR code would work, right, Elizabeth? Okay, for eligibility. Okay.
For eligibility, okay.
Eligibility for our home is determined by DCO, just like eligibility for any category. Now, if you're picking a plan, I think you can still do that through the Access Arkansas portal,
I think so, yes.
but it'll take you to the exchange to pick that plan.
And of course, if you have any difficulties or any questions, you can always reach out. We're happy to help as well. Good questions. Anyone else? Okay, if you think of something, you've got my email. I look forward to hearing from you. All right, we'll have Elizabeth go over the community engagement requirement.
All right, I'm back. As you can see, I'm not Mary, and she was supposed to present this today, so bear with me. She knows a lot more about this than I do, but we'll take a stab at it. All right. As Jennifer said, the omnibus, whatever, One Big Beautiful Bill. I'm sorry, I'm off in La La Land. The One Big Beautiful Bill Act, or OB3 as I commonly refer to it, requires that we do community engagement requirements starting January 1st of 2027. As she also said, it does require the 6-month renewals as well, starting in July 1st of 2026. So we had initially, as you know, asked to do work requirements in our Opportunities for Success waiver amendment that's pending with CMS. We have looked at that requirement compared to what we have in the community engagement requirements under the OB3, as I'm going to call it now. And we have kind of regrouped on our plan to move forward. And so we wanted to present this plan to you today. We have some recommendations that we have presented to leadership that have been adopted, and so that's what we're talking about. So we are proposing and going to move forward with a soft launch that's going to start in time for those redeterminations, July 1st of 2026. This is going to be going through when you go to do that redetermination, just like you would for a work requirement. You know, are you compliant or do you meet an exemption? But we will not impose any penalties at that time, and we'll get into that a little bit more. It's really just an operational readiness and an informational campaign so that people will know where they stand and try to help educate people on what they need to do to remain eligible. So full implementation with closures and penalties will come on that mandatory January 1st, 2027 date. And CMS has indicated that although there is a good faith exemption written into the bill, they do not anticipate giving any out. So there's really not a lot of good faith exemptions. You know, the standard reasons that you get good faith exemptions from CMS, they have already kind of come out and said would not necessarily work here. So we're moving forward with the January 1st of 2027 implementation date. It will be timed with our new 5-year demonstration waiver because our current demonstration for our home is up on December 31st of 2026. We will not implement the success component, the success coaching component until after January 1st of 2027. We have a goal implementation date of July 1st of 2028. And that is simply because that's another component that adds a layer of complexity to that implementation that there's too much already. And if you're not familiar with success coaching because you didn't closely follow our Opportunities for Success waiver application, what that is when we had proposed a work requirement as part of Opportunities, it included success coaching. Success coaching is a model where if you're not meeting the work requirement, we assign you a success coach who helps develop a plan for you. It could include some job training, some education. It could include some housing security, addressing housing security or food insecurity needs. Anything that you need to have a stable life so that you're able to go to work. Because a lot of times readiness to work is more than just job skills. So we are hoping to still move forward with that. It is still going to be part of our new demonstration waiver, but we are going to delay implementation. All right, so soft launch. Starting on July 1st, Aries will begin running the renewals that include the ex parte data matching. The OB3 requires ex parte data matching, which is something we already do in our renewal process. You may be familiar with it. It's where we look at the data sources we already have to try to determine you eligible without really having to get any information back from the beneficiary themselves. So if we can do that, we keep your eligibility going for Medicaid, and we don't make you submit anything. If we don't, then we send you a renewal notice. Same thing that we're going to do for work requirements. So we're going through now all of the different data sources that we're going to need to data match, and part of what we're hoping to do during this soft launch is perfect that data matching and get all of those things in place. It's a lot of external sources that we don't currently use to try to do that. The notification will include it will include whether you would be considered compliant or not, but it will very clearly explain to you that there are no penalties at this time associated with this, but that if it were in force, this would be your status under the work requirement. And then in December of 2026, we're hoping to go live with our customer service center vendor. Hopefully that solicitation will go out soon so we can make this time frame. That vendor will have a customer CRM system, customer relations management system with bilateral connectivity to Aries. And it sounds like I'm really technical when I say that, and I'm not. So please don't ask me what any of that means. But we are hoping that one of the things this customer service center will do is an outbound call center that will do verification. So if we're not able to do ex parte matching to determine your compliance or exemption from the work requirement, the hope is that we can then pass that along to this outbound verification center that can make outbound contacts to you as a beneficiary to try to help you submit whatever verification is needed. All righty, so the good old tiny timeline. And if you can read that, I'm impressed. I have to have these little reading glasses. So this is a very detailed timeline. We can send this out to you. I don't know if you want me to go through all of this, but we are going to start this year kind of shopping out this idea, letting people know we really don't want to keep people in the dark about what we're doing around this. We want everyone to know what to expect, when it's going to go live, and kind of what we're doing. So starting right now, we're going to start sort of socializing this idea. We're working on the RFP for the Customer Service Center to get it out the door. It does have to go to both CMS and FNS for approval because we are going to add SNAP as part of the Customer Service Center. So we really are trying to do a no wrong door approach to DHS overall. So because that's two federal agencies that we have to have approval of, we are trying to go ahead and get that submitted in advance. There is a federal shutdown, so hopefully somebody's there to read it. But we are working to get that submitted now. The reasoning for the APD approval in advance of the launch, while we don't need CMS approval to do a pilot or a soft launch, we do want the enhanced funding that they give us so we can get 90/10 like we get on our home for technical build-outs of Medicaid systems. And so we really want that money for the state. So that's why we're asking CMS in advance. In November of 2025, we're going to start those fund systems changes where all that bilateral verification language comes into play. And people smarter than me will do all of that. We're going to submit the new Our Home application in December of 2025 to renew our waiver, and that will include a lot of the information around the work requirement. We're going to start the promulgation in I guess I need to move that on. Start the promulgation process in early 2026. So any rules that are going out with this, with our eligibility manual and then our counterpart provider manuals will go as part of that promulgation. Of course, in December, when we do the waiver, submit the waiver, we will have already run it for public comment at the state public comment level. Sometime in January or February, we'll have to do the federal public comment. So, each 1115 demonstration actually runs through 2 public comments. A state one before you submit to CMS and a federal one after. We'll answer public comments in February and run it through legislature in March, hopefully with promulgation start date in early April. Go live in July. So there's a lot more there, but again, I don't want to bore you with a very detailed timeline. Once we start going live, we'll move forward doing the redetermination as we stated, with the goal of, again, of launching the customer service center by December, so we have at least 1 month of having that outbound verification before we actually implement January 2027 as required by OB3 for the actual penalties. And then post-launch, we'll continue to monitor, work out any kinks. I know that's not on there, but don't you worry, that will be happening. And then we'll work with CMS to develop out success coaching. It was a lot of information in a short amount of time. Please do go look in that timeline. Like I said, I didn't want to go through every single one of those 80 bullet points. I don't know that you care that we're going to ask CMS for permission on every single thing. But if you have any questions, as I'm sure you will, please do let me know.
Hi, I'm Yukiko from DDPA.
Yes, ma'am.
Super simple question. It's individual with IDD. Are they going to be?
They're exempt.
Thank
Yes,
you.
ma'am. There is a category of exemption based on diagnosis, and the work requirement, and I probably should have said this at the very beginning, I'm sorry, it only applies to the our home population. So only that population that's covered through expansion, 19 to 64, 138%. So if you're covered under the DD waiver, this doesn't apply to you at all. Great.
Hi. I was really excited to hear that you're, I guess, working on this for SNAP as well for the same.
The Customer Service Center?
Yes.
Yes.
It sounds like the same maybe reporting system for work requirements.
Oh, I don't know about that's a Mary question.
Okay.
But the Customer Service Center is going to include the SNAP
Okay.
customer service help. So what we want is a no wrong door into DHS policy.
Okay. Okay. So maybe I misunderstood that then. One thing that I have been thinking a lot about, just as programs add work requirements, having one place where an individual can report those work requirements might be really helpful. I think about childcare; you have to report your working hours for that. For the school readiness assistance, for SNAP, for this, it might just be really wonderful if our state could do some of that all together. If that could be thought of. So I know that is now, I think, over at ADE for the child care piece of that.
It
so
is.
that might not be as easy since they aren't there. But that's just an idea. The second piece, in thinking about access to said portals, I know the last time we did work requirements, that shut down in the evening. Is that still going to be the plan, or will it be open 24/7?
That is, again, a Mary question, but I do know that the plan was to work through a lot of, we want to take lessons learned from 2018 and not make it hard to get us the information that you need to get us this time. So I'm sure that will be addressed by Mary and the Aries team.
Great.
But make sure she is aware of that. And I think letting her know your thought on SNAP too, because she does administer that program.
Just thinking
And
a lot of the same
yes.
families are probably served, and if they're having to put the stuff into multiple, I just think about the work it takes to do that kind of verification and upload of things and clicking boxes and logging into 3 different systems seems
Yes.
like it might be a big challenge.
And I believe, if I'm not mistaken, and I'm trying to remember which iteration, there were 3 iterations of OB3, and then we have a state law and a federal law, so it gets very complicated. But I'm pretty sure if you meet the SNAP work requirements, you also meet the Medicaid work requirement. So
right,
it's
being able
considered,
to do that
yes.
kind of ex parte,
It's sort
maybe
of
sharing all
yeah.
the, yeah. Okay.
So that will be part of what they're matching too. Is if you're meeting SNAP, then you're automatically, I think, deemed to have met Medicaid.
Okay. Last thing I wanted to ask about was I think a lot about our community-based providers and their training and all of this, and maybe I missed it in the tiny words, but is there a time during all
Yes,
all
there
of
is
this-
actually.
Okay.
And
the time
yes,
in the
it
words.
should be in the tiny words.
Okay.
It should be
Great.
in, I think, early 2026, but don't hold me to that
Right.
in the
And
tiny
then-
words.
But then maybe coming
Yes.
back once it's going to go live and trying to, okay.
Yep. It's in February doing stakeholder and legislator outreach. I think that's where that fits in. It's in our tiny words.
Maybe I'm thinking about something a little bit different, but I'm talking about technical training on helping maybe community providers who would be willing to support families as they try to navigate the new systems. That
Yep.
might be really helpful.
And that-
So it's not
yes.
just DHS having to carry that
Gotcha.
that weight on their own. So it might be there. You might find some willing partners willing to be helpful in getting people.
I think if they are a community partner, we'll take that help. So
I know, Elizabeth, we talked about this a few meetings back, the transportation piece that's so important for this population. It's already limited resources. Have y'all looked into that anymore? And also, that being said, a solution is ARS. We talked about partnering with them. If you guys are going to do that, like my son's with ARS through Project Search, they're paying for his transportation. And I know that we have limited transportation with Medicaid. Have y'all looked into that as you move forward to make this work requirement for this particular eligibility category?
So are you speaking specifically about transportation to get them to work?
Or any certifications, like VR also provides transportation to do programs like Project Search and internship program, but any certifications or training programs so people can go to work.
So we haven't specifically looked at that. I know that success coaching, that would be incorporated in as part of that model, that if transportation is one of the barriers you have, then that they, of course, would help you find alternate means of transportation or whatever it was that you needed. So that will hopefully be part of that as we start to implement that. But it's not something we've specifically looked at for the minimum compliance standard.
And will this population be working with Arkansas Rehab Services, because they'll help develop a vocational plan and they can probably offset some of the cost for you guys to provide this program?
I don't know the answer to that off the top of my head. Like I said, I'm filling in for Mary. Bear with me, but that's a good point. And if you'll help me remember, Crystal, we'll ask Mary. Sorry, I'm not as eligible about the eligibility stuff as Mary Franklin. I think it's me again, right? Yeah. Sorry, guys. You're stuck with me again. Hopefully I can answer a few more questions about this, though. Okay, so this is the OB3 bill analysis that you guys had asked for last time. You had asked for what's the impact to Medicaid from the One Big Beautiful Bill Act. And so this is it. Common sense federal law that delivers hundreds of $millions in new federal funding to support Arkansas healthcare transformation. The rural health transformation funds are the primary source that you have probably heard of. They support Arkansas Medicaid work requirement reforms, previously blocked by the courts, protect Arkansas taxpayers with program integrity reforms, and have minimal impact on our budget. And let's all remember that last bullet there, because I think that's the key takeaway. We are not anticipating huge impacts from a lot of what was in the OB3. And I'll walk through that. So our FMAP is not changing. Our federal medical assistance percentage, which is the percent of dollars that the federal government gives us to match our Medicaid program under OB3, is not changing. Now, it changes every year because of just general economic factors in the state. It goes up and down and fluctuates based on how Arkansas's economy is doing compared to the rest of the nation. As you probably have heard me, Janet, and anyone else say, ours actually went down last year. That had nothing to do with OB3. Does not change income eligibility for any category of Medicaid, and it does not impact negatively key healthcare sectors, including hospitals, nursing homes, outpatient clinics, pharmacists, mental health providers, DME suppliers, or insurance premiums. For Arkansas, there are no state-directed payment changes. We don't use a lot of state-directed payments, and if you're not familiar with state-directed payments, they are used in managed care. Congratulations, I wish I didn't know what they were. But they are used in Medicaid managed care systems to pass. So sometimes if you want to do a supplemental payment in a managed care arrangement, you'll use a directed payment. So it's where the state tells the managed care entity, you have to use X number of dollars to pay this. We're directing the managed cares to pay a certain way. Under the OB3, let's go back. Right now, today, prior to the passage of OB3, a Medicaid agency can use a state-directed payment under managed care to get rates up to what's called the average commercial rate, which is what is the average all the commercial payers in the area. As of passage of OB3, Medicaid cannot do that anymore. We're now limited to what's called the upper payment limit, or Medicare, which is the standard fee-for-service limit to a payment rate. When I look at paying a physician in fee-for-service Medicaid, my upper payment limit is Medicare. When I pay a hospital a supplemental on top of their per diem, my upper payment limit is Medicare. This ability of managed care to go up to average commercial rate has gone away under the OB3. We did not use state-directed payments in Arkansas to get up to average commercial rate, so it does not impact us. It does not impact our home. Does not impact most provider taxes. We have one in Arkansas that it will impact, and I will tell you that is the ambulance fee, which is our newest one. It's the only one that is above any of the thresholds in the bill, and it will cost about $190,000 to the state starting in fiscal year 28, and that's federal fiscal year. Federal fiscal years run October 1st to September 30th. All right, we talked about work requirements anyway already, so I'm not going to go back over all of this. There is a $100 million in the OB3 to support systems changes for the work requirement. I think that's the only part I didn't really cover there. And then the OB3 does allocate $50 billion to the states to support rural health transformation. Each state gets a certain allocation. Every state gets it equally, and then the half of it, and then the other half will be based on the proposals. So we expect to receive at least $500 million. That proposal is due November 3rd, and you were able to submit proposals to the committee drafting that, I think up until last week, and so they're working on that now. So it does require us, as we've already stated, to conduct eligibility reviews for only the expansion population. So if you're not in our home, this doesn't apply to you either. But for the expansion population, we will do eligibility redeterminations every 6 months. And we do not expect that we anticipate that to be a program integrity measure with no meaningful financial impact. Retroactive coverage is decreasing from 3 months to 2 months for traditional Medicaid. That is a bit of an impact for our population. We do currently have 90-day retro. It's going for 3 months to 1 month for expansion. That is not an impact to Arkansas. We are already limited to 30-day retroactive eligibility. It's increasing from 0 to 2 months for CHIP, Arkansas, our Kids B. So we do not, with all of the different changes there, but we don't anticipate that will have a financial impact. Some's going up, some's going down, but overall kind of netting out. It is changing the PERM error rate. Payment error rate measurement is what PERM stands for. That's not the thing you get on your hair, unfortunately. That would be more fun. But anyway, we are monitored by CMS on our PERM error rate every 3 years, and so it is going to, and Mary is better at this one than me because this is really about her eligibility. But states with error rates above 3% will either have to repay the excess work or do a corrective action plan. We're pretty good with our PERM error rate, so we're not anticipating a lot of impact here either. All right, waiver reforms. So there is a new requirement for all 1115s to be certified as actuarially sound by the Office of the Actuary, or OACT. It's not changing the budget neutrality test of an 1115, but it is requiring that it be certified by an actuary now, which has never been required in the past. That has always been required of our managed care rates. That may be a little more than you actually care to know, but there it is. Again, no meaningful impact there. And then it does create a new 1915C waiver option that allows home and community-based services for individuals based on state-established criteria that define whether individuals would otherwise need hospital, nursing home, or intermediate care facility levels of care. That's similar to what you're already allowed to do in a 1915I, but it allows you to do it in a C. And then SNAP. And I'm sorry, Mary would be the better one to answer these questions, but I'm going to go through this bullet list for you, okay? Expands the SNAP work requirement for able-bodied adults up to 65. That mimics what they're doing on the Medicaid side with the expansion population. Protects taxpayers by challenging states to reduce their SNAP payment error rate. Same thing there. You have a payment error rate. If error rates are below 6%, there continues to be no cost to the state. Ours is currently 7.9, but we're working to reduce that now. I can't tell you how, because again, that's Mary, but she is working on it. Apart from that, DHS views this as a program integrity measure. This does have a cost, this last bullet. It is increasing the SNAP admin requirements for the state from 50 to 75%. I think that actually is going into effect now. Yeah, now. Currently, admin costs are split evenly between the states and federal government at 50-50. We're going to have to put up another 25%, which is going to cost about $47.8 million SGR. Or $23.9 million SGR. And I think that's it. Please, not about SNAP. Okay, good deal.
I mean, I have things to say, but no.
All right, quick question. Our PASS program is currently in a 1915C waiver, yes or no?
It is. It includes a 1915C.
Okay.
It's a 1915 BC combo.
So our PASSes already fund home and community-based services for their people. So the change to allow what used to be done in an I in a C is a no impact to us, correct?
No, we're not going to. We have an I as well in our PASS for our behavioral health population. They're not required to meet the same institutional level of care standards. So.
Perfect.
When will the state be putting out its rural health transformation application when it goes in, I guess?
I am assuming we will, and I'm not on the committee that is drafting that, but I'm sure we will. Yes.
Cool. All right. We're all eagerly awaiting what that looks like.
Yeah.
I want to say from the Arkansas Hospital Association and all of our membership, as you have to do this enhanced periodicity check for eligibility, if there are things that we can do to help you in our systems, we are a willing partner because we recognize sometimes we have data and information about people who come to see us, whether they're frequent flyers or just had a really bad day, right? Nobody likes to come to the hospital except a first-time mom. She's excited. She has new clothes. No one else wants to be there. So that, when you know that, just recognize that we're super excited to try to help where we can, where it's possible, in ways to help streamline that process and maybe help the technology do the technology work.
Okay, thank you. Anybody else want to offer? No.
Yes, I mean, I will just say, I think yes. I mean, broadly, I know kids are not directly affected by this, but I know that many of our practices are concerned about full families, and we know mom and dad's health very much impacts the kids' health. So if there are things that providers can be doing or places they can call directly as a provider representative to help families get back in. I think about our Healthy Steps practices, for example. They're supporting moms with littles who are in that postpartum period, helping them reconnect to health coverage if they lost coverage postpartum, et cetera. So I think there are a lot of folks willing to be there at the table. So that's all.
So a couple of things, just to let you guys know, I announced this at the Medicaid Client Voices Council meeting this morning. We are working on putting in the redetermination date on the eligibility check. Yes, it is informational only. Let me state, it is not to be relied on for billing. You still have to do your eligibility checks. But we do want to have that there. We've gotten a lot of requests from providers that are like, we'll help people stay eligible if we know when they're coming due. So we're trying to make that information available through the eligibility check. So, I mean, that is something you can do. And keep in mind that the way the work requirement under the federal law works is there is a look back for eligibility determinations. You have to have been compliant or exempt that 30-day period before your eligibility. So, that's something that's important, and that's at your redetermination as well. So, whatever period we decide, you have to show that compliance at your redetermination. So that's important. It's not just that you can become compliant.
I know I heard it and you told us, but when does the 6 months for our home go into place for re-eligibility?
Sure. So the redetermination every 6 months starts July 1st of 2026, the same time as the soft launch. But there will be no penalty for not meeting the work requirement or having an exemption until January 1st of 2027. And there is a lot of ways to meet compliance, and there's a lot of ways to be exempt. So, we'll have information out on all of those. I don't have them memorized, but there are quite a few. Any questions online? All right. Thank you, guys.
Okay. So, a little about working on the collaboration between the MCVC and us. Currently the MCVC comes up with some ideas and brings it to us to discuss, and then we are supposed to give feedback or recommendations to DHS leadership. I know we've only had one meeting, so that hasn't happened. And that's more of kind of a reactive solution, and we were looking for ways to kind of make it a little better. So one plan that we came up with is DHS leadership is going to set a strategic focus in areas based on federal priorities, program data, or access rule requirements. And the MCVC and us will collaborate with the teams to implement and monitor those and refine in areas. And then they'll communicate. That's going to create that two-way loop. And so it's going to be more solution-oriented versus, reactive to that. So that's going to change a little bit. So, and it also will help to make sure that we're in alignment with federal priorities and state priorities. And it will also help with our compliance because we will have to start submitting a report once a year starting in July. And it also kind of empowers both committees to, talk and work together to create that loop to do that. Are there any questions about that? I know we haven't made it very far in that process. So, okay. Next quarter agenda items. Brandy, do you want to? Will this be? This is Brandy's last meeting with us, so she has fulfilled her.
I will not lie, we've struggled coming up with proposals for y'all because most of the things that we discuss in Medicaid Client Voice Council really pertains more to the DHS leadership. I mean, it's all agency type issues. But a couple of things that did come up that we felt like providers could weigh in on. The first one is it has been discussed that there has been reported delays in autism diagnostic testing. So many parents whose children are Medicaid beneficiaries are reporting that they are waiting 3 to 4 years just to receive diagnostic testing. Without this testing, these children are unable to qualify for critical therapeutic or behavioral services. So we're asking the providers to weigh in on, investigating current wait times for autism diagnostic evaluations across the state, to explore partnerships or funding mechanisms to expand testing capacity, and to consider prioritizing children awaiting diagnosis to prevent long-term developmental and educational impacts. So that's number one.
Are there more, or is that it?
There's one more.
Okay.
One more. And the second one I'm going to let Jennifer kind of expound on. So the second one is kind of probably along those same lines, but early childhood intervention. It's been reported there's been a lot of refusal of services from providers, and we're wanting to know what those reasons are.
So the reason I brought this up, I've been in early childhood for 7 years now as a developmental therapist and a teacher and all of those beautiful things. And I'm SPED certified. So my big thing is I would just like to know why some doctors are very much against having all of those services in one location, because we do get a lot of hit back on that and a lot of doctors that don't want to sign off on those services. If they do not sign off on those services, the child cannot attend the certain centers for preschool educational benefits. And then we just kind of want to know what the hang up is there. If it's a fight between service providers or what's going on in that aspect.
I think it kind of piggybacks on our first meeting where we brought up complex care, medical, behavioral, in my eyes, IDD, like my child has 12 diagnoses. And where does it go from that referral? Are we going to be able to get, as member, what we're hearing is that sometimes it's disjointed and you don't have all the referrals that you need. And then you go back and you're like, well, I need this for speech and this for over here at Arkansas Children. So we're just wondering kind of what that process looks like in a flow process from the PCP forward. I know, Jen, we talked about integrated care earlier, but where does that go from that first appointment?
Okay, I will say, kind of piggybacking off that, the next meeting, we do have some past background and some information on past already on the agenda for next meeting.
Okay, this is not managed care, but I'll talk about the autism. I mean, I guess we can piggyback on the diagnostic piece. I mean, we need more psychologists. You have to have the triad to do the MCAT. You've got the doctor, the speech, and the psychologist. You still need psychologists, and you still need people that are trained to do the ADOS. We're not seeing waiting lists anymore. I don't know. I know at dentists there used to be massive waiting lists, but I thought those were cleared up a lot.
I mean, I guess that preschool kids, I've got 20 kids right now that have been waiting for over a year.
For autism or for like a redetermination?
I mean,
Appointments are being set up 6 to 8 weeks, and then they call back and say, sorry, we have to move you to.
Is that it?
oh, good. You have two. You have another microphone too. Okay.
I mean,
So I do not speak on behalf of any specific providers. I just run the Pediatricians Association. But the thing that I will say though is, I know several of our pediatricians are now diagnosing in their clinic. They are using a speech therapist as the other person, and we worked with DHS to make sure that that speech therapy diagnosis code for autism was a separate code from the intake at speech therapy, so that none of the EIDTs or the other speech therapists would not be able to bill for their intake. Had great work with Ms. Brzee on that. But anyhow, so we did do that, and my understanding is that that dyad of a speech therapist and a pediatrician can diagnose autism if they are trained in the ADOS and all the things you just mentioned, and you do not have to have a psychologist. And so that SPICE model that Partners for Inclusive Communities and Elizabeth Cleveland was training on has been kind of, some people have started to pick up on that, but you do have to have, I think, I don't know where that is now. I was going to say we had several webinars for our members on it and have had people. When Elizabeth left, I don't know really how that kind of carried forward. But one example, I know I have a member of ours in Monticello who's on my board who is wonderful and has a speech therapist who comes into his clinic X number of days per month, and they do all their autism diagnoses for Southeast Arkansas, like on that day. And so they are doing that. There is no delay, shouldn't be a delay to get into the waiver program or anything like that if all the things check out on the diagnosis. But it has taken some time to get all those agreements right. The billing code, he was the primary care doc who helped us get through the billing issue because they were having that problem of whether it's a speech intake or a diagnostic speech therapy visit, because he did need a bill for that to be able to pay a speech therapist. So anyhow, I don't know if that helps on that front, but I will say that I have not heard anything about 3 to 4 years from anybody anywhere. So if y'all are hearing that, more specifics on that would be helpful.
We talked about this earlier, Paul and I think I'm on Understanding Arkansas Medicaid Waiver. I'm on the board at Arkansas Autism Foundation and a couple other support groups I think parents just don't know that about the DIAD or the IAD if we could put it out there where somebody could, and they would know what pediatricians actually do that, because you don't know and you still think it's the old rules, kind of like re-eligibility for the waiver. Now you can do a Vineland, an adaptive assessment of a whole psychological. Right. I think the problem is the message. We would love at Arkansas Autism Foundation to get that word out or help to get that out. And the other groups that I support for autism. But I think parents just don't know, because I went to a recent brunch and it was about 8 parents that are still waiting on testing, and one lady was 3 years, one lady was 4 years, and they just. And I think it also comes down to your benefits. But again, if we could get a communication out that it just needs to be those two people and who does that, I think that would help a lot.
We have communicated this a lot. We've had multiple webinars. We had it at our conference, not this year, but the year before. Elizabeth Cleveland came and talked about it at our conference. I mean, we have done everything we can do on the pediatrician side. I think we've done, and I will just say we are happy to do more. I think something that would really help people would be an incentive, because it's sometimes hard to get folks to change how they practice, but figuring out how to build those contracts, template contracts, I think that was some of what the SPICE model had. I will say I think the doctor in Monticello is using Cobalt, which is affiliated directly with, I think, the Dentist Developmental Center. So it doesn't do the full diagnosis, but it does almost, it's it's a piece of it, but then you still go into Dentist Developmental Center, I believe, or Cobalt, or the Schmeeding for the final diagnosis. But some are doing the diagnosis. So that is what I know about all that.
Is there something that we could take from your webinars? Like, I had no idea y'all do webinars. I did when I worked in my other life, but like for parents to get that out there, like a memo that's simplified that says, hey, you can, and break it down, because I think it's the parent venue that we're not maybe necessarily getting all of that.
Pediatricians actually making the practice change. They may know about this, but actually saying we want to have a formal relationship with this speech therapist to say this is a thing we want to do in our clinic, because it's a different way of scheduling, and it takes a lot of work to build the right infrastructure, because it's a different kind of clinic day than your regular clinic day. You're not going to be in and out in 10 minutes for this, right? You're going to have a half day a month where you block for 4-hour appointments and have several things going simultaneously, and have a big diagnostic day rather than a regular sick and well child visit day. So it's going to be a totally different way of adding on something different, and that sometimes takes a little bit of push requirement / incentive characteristic.
Yeah, and the schools knowing you were, Carrie, tell me, you're on the Jerry. Jerry's on Department of Education, special education, assessment teams. If they knew that, then they could send them to the pediatrician, but I think they don't know that. And that being said, just a question to Beth, are the passes going to cover that, or are we going to require psychological? Because the PCSPs, we get asked a lot of times for the psychological to give back as a waiver provider to justify the diagnosis to move forward.
Hey, Elizabeth, are
y'all going to cover that?
I don't know the answer on coverage.
Statutory diagnosis change, I'm pretty sure. We changed, yes, that was changed law in 23, I think.
I feel like the definition of ASD used to require a 3-pronged diagnosis, and it's only 2 now. So that was either a regulatory or a statutory change. And so I don't know how that impacts the passes. Don't make me speak to that, Bess. But
well, I know for a while there was a fight between, is this a behavioral health thing, or is this a waiver, a CES waiver?
Right.
It is a DD diagnosis.
But it's in the DSM.
Yes, I know.
So it's
under state law.
Yeah.
It's a DD diagnosis.
But it does have to be verified through a full psychological. It can be through this process.
And I would say, Amy, I don't want to speak on generalities here, but are these kids in any type of services already?
Yeah.
Yes.
So maybe Yukiko and I and other people could maybe do some provider training on resources available for people that need that. Because I know that, at Kids for the Future, this has nothing to do with managed care. This is my other hat. We would get people, and my sister actually is a psychologist, so she would do some of the training, and then she's not doing it anymore. So in East Arkansas, and this is not necessarily just the ADOS, but any type of psychological training, it's hard to find people, especially East and South. So, I can see waiting lists 3 to 4 years in El Dorado or in Helena. Right. And actually, Kids for the Future partnered with UAMS, and then again with partners. Same thing? No, U of A. Anyway, in Helena. And they had a doctor come in half of a day, once a month. We would send our speech therapist, and then that stopped. Right. So this is an access problem. It's very hard to solve. But I think some provider training on our side, on DDPA, on whatever side I'm on, I think could be beneficial as well.
And Andrew at Inner Circle actually has a group, and I can get y'all his contact information, where he started some of that, getting providers together to do trainings and just getting feedback, like a networking group.
I mean, DDPA does a massive
can't remember Andrew's last name to
conference
save
every
my life.
year.
It's in my phone, but I will get it to you.
Like that would be a
Thank
great, great thing. And then, obviously on the managed care side, the passes, I know just from Empower, where they were trying to identify where some of these testings could take place on the care coordination level. So there could be some room for improvement there.
No, go ahead.
And the DDPA, we're the Provider Association, we're actually in the planning for coming up some one-day training session or possibly conference in the future specifically for guardian and parents. So maybe there's something.
Yeah. Well, just even a recorded training of like your kid has autism in Arkansas now. Or you think your kid is, you think your kid has autism. What do you do next? And I had a thought if anybody knows of any grants or community investment opportunities that could be used by, for example, a pediatrician association to help incentivize providers, like mini grants, to say like, here is some money to help offset a half day of planning and a draft contract. Like just the time and support we could provide for that. If y'all, I do not work in the DD space a ton, but if y'all know of anything available, I'd love to just reach out and chat and partner. Okay. Oh, great. That's great. Let me know. Because it's not a space that I have any funding right now, but I'm more than happy to try to build some infrastructure there, especially if we have targeted areas of the state where there is something we need to do. And Jennifer, you also asked about early intervention and refusals and kind of the referrals piece. Is this like for an EIDT? Because I know there are some folks who really have a strong preference for the least restrictive environment. And if the kid, I know there are, if you do not meet the newer-ish within the last, 7-ish years or so, when did it change? I feel like it was like, this was like right post Affordable Care Act, I feel like days. That was like 14, wasn't it? 13? No? Okay, yeah. But anyway, yes, pre-pandemic, before the pandemic. But anyhow, when all that changed and that it got, you had to have at least two diagnoses, I think, to get into an EIDT for the childcare piece of it.
You have to have developmental
delays,
developmental delay, and then you have to have at least one service as well to continue going there.
All those,
and so what I'm saying is, some of those services or some of those providers are saying, "Well, I no longer think that speech is helping this child," and that was the only service they were getting, so they're kicked out. And so then we're like, "This child needs like." Well, no, like the doctor just doesn't sign off on it. And they want him to do outpatient instead of inpatient services. And so then they get kicked out of the center, and then they have nowhere to go because nobody will take this child because they're severe behavioral need and they're severely autistic and they just cannot function in another school setting, but they don't get in anymore. And it's happening with developmental delay too. I do the testing on a lot of children and they do not qualify for me, but they're severely autistic and they need all these services. And now they're being kicked out, which we do have EPSDT as availability, but it's not going to happen forever. Like they're going to be done with that.
Yeah.
So
I think you're speaking to an access to early child care that's inclusive issue that may not be a healthcare issue. Because I get that. It's Medicaid dollars versus, supportive, integrated, or inclusive childcare. Partners did a lot of trainings on inclusive childcare a few years ago, too. I hate to keep hearkening back to them, but Ann Patterson is just one of the people that I have really loved working with over the years, and she did a ton of work in that space on working with just regular childcare centers for kids under the age of, under school age, under kindergarten age, to try to do that. in another hat that I wear, I'm on the Little Rock School Board, and one of the things I know we are working very, very extensively with our child care program and early childhood education for pre-K to help continue to build inclusive environments that help support kids no matter where they are. We have open behavior classrooms for kids who have those behavioral challenges that they struggle to function in a regular pre-K classroom. But I know that is also, again, like outside of the Medicaid world. So, yeah. You want this back?
Okay, back to the agenda for next meeting. Any things you guys would like us to put on the agenda for next meeting? Maybe some rural health transformation.
Because we should know a little more about them, right? I don't know.
If we know more, I will put it. If we know more for the next before the next meeting, I'll put it on the agenda. If not, I will have it as a maybe until we know more. Is that acceptable? Okay.
The current versus planned dynamic, where you talked about strategic focus areas based on federal priorities. Like, do y'all already have ideas for what some of those might be, and could they play into the bones of a strategic plan? You're the president.
So one of I can't answer specifically for Arkansas. I'll let that, but kind of that idea came from Delaware. I have a contact who does the MAC in the back in Delaware, and that is what they do. So when the federal government says, hey, we need to make this change in the 6 areas that our MCVC and our MAC is supposed to help with, they'll say, hey, we need to make this change. Will you please help us? Or, hey, this form online we get a lot of complaints on it. Can you please help us? And we kind of use that to kind of help. That being said, that was based off that we thought would help things a little bit.
I don't know that there's a big, giant document called the Medicaid DHS Strategic Plan. I wish I had one for my life. But anyway, and so I'm not going to promise you that. Do what?
I don't need to have a strategic plan.
What I was going to say is one of the things that we are looking at is that good old Medicaid Sustainability Report, MSRP. I don't remember what it stands for. But, that was put out a couple of years ago. And we've actually done...
Healthier Arkansas?
No. You're thinking of... You're thinking of Melissa's roadmap, yeah. I believe. That this was about... I've kind of read.
Oh.
It wasn't just about money, but it was a lot about money, because one of the big things that makes Medicaid sustainable is continuing to be able to fund it. It's a big piece, probably the biggest. So a lot of what it looks at is how to make it sustainable from a financial standpoint. But it's in like 8 or 9 different areas, and it talks about rehab and HAB and PASS. It talks about our home. It talks about transportation, hospitals, all the long-term care for you guys there, because I know we haven't touched on you guys a lot today, but you're in there. So everybody's in there. I think
that can just die.
It's not dead.
Oh, no, we don't have to talk about that.
It's not dead. And we're actually moving forward on, we have already moved forward. This is not a big secret on a lot of the things in there. And so I think that could be something we could use as a way to bring some of those things back up to you without recreating a document that would have to go through 8,000 levels of approval and would never get back here. So,
well, no, the question was, and Melissa asked it, like, what do y'all want to see? And we're like, we're supposed to be advisory council. How can we advise on something that we don't know?
Right.
So that's kind of where, and I know there's not a massive, beautiful, pronged strategic plan, but if there are areas that we can target, maybe those areas or other areas coming from voices, great. But to make it worthwhile.
Yeah. No, and we agree, and I think that's one of the things I was talking to Paula about it earlier, and yes, Amy, I see your hand, so we'll get to you. We do need to be a little more strategic in saying these are the things we're working on right now. What do you think? What are your thoughts as providers? And then to the Medicaid Client Voices Council, what are your thoughts as beneficiaries of these services? Jerry and I are meeting frequently right now on a school nurses project that maybe we could bring to you. So things like that we know are coming down the line. And then you can hear from Jerry and not just me. Okay.
This is just a suggestion. I did some work with some MAC committees in other states.
Please.
And what we did was we took our specialty folks, our subject matter experts, and we had separate meetings that applied to those areas because that was the area they knew the most. And then we brought it back to the bigger meetings. And we're kind of doing a little bit of that right now with our client voice council. We're having separate meetings, and then we're bringing things to you. Well, not, like separate emails, and we're trying to make sure that we're organized when we come to you guys. That we're doing pre-meetings, like prep meetings for here.
Well, I just mean, are you talking about us having subcommittees?
Like if we could meet, like some of the things that we're going to bring to y'all were actually more for DHS, but they do involve y'all, and then DHS will bring to you. But like expertise areas, if we could do some separate, I don't know what you want to call it, subcommittee meetings or whatever, and then bring it to the bigger strategic plan as a whole so that we feel productive and effective, in the end, and we have action plans of what we're going to do. Like we know we're going to get together after this with cards and do whatever, but what's the next step so that we take what we do in here forward?
Okay. Yeah, that's something to think about. Thank you.
I feel like I'm maybe not following the bylaws and sharing the floor enough today, but one other thought I had were just like, what are some of the, and some of this in my outsider view may depend on what's in the Rural Health Transformation Fund plan for the state, but like, what are some of the big rocks ahead? I know you and I've talked about a pediatric PCMH program. I know we've talked about integrated behavioral health and preventive behavioral health in the medical home potentially. I know we've talked about rate reviews. I mean, those are some of the big things I have on my radar, but like, even if we all just like said, like, what are our top 2 or top 3 things that are on our radars, and that could help maybe compare with your Medicaid sustainability list and maybe think about.
Yeah, and here, I have a question too. Do you want this group to be the group that helps you with provider manual changes and rule changes and that kind of thing? Like, do you want to vet that stuff with us first to be like, oh my gosh, here's a lightning rod that we're going to bring up from the hospital or long-term care or whatever? Do we need to serve in that role, or is that not at all our role?
No, I think that can be. I mean, there's a statutory or regulatory list of things, and one of them is advising on policy. So yes, I mean, I think not every time. I mean, there are some things that are statutorily mandated that I can bring to you, but it doesn't matter if there's 8,000 lightning rods or none, we're going to move it forward.
Right. But rule changes and provider manual changes, this might be a good group to say, hey, that's so well-intentioned, but guess what? On the implementation side, we can't pull it off. Or here's a roadblock we have to being able to pull it off, right?
Yeah.
But if that's not the purpose of this, totally fine. It's not like we can't get to you in public comment in other ways. But to me, I feel like with the expertise in this room, we'd be a great vetting of, we've got these 5 rules that we have to get done. And, Jody Ann, your hospitals might not like one of them, but let me explain to you the rationale, the reason why. And if I can't get there with you, it seems like this is a great group to say, okay, we've identified the problem. Is there another way to get there that doesn't cause the same kind of harm moving forward? So, and I'll be honest, when I first, got asked to participate in this, I was hoping that would be one of the big things we could do, is to be a safe place, for lack of a better word, to really think through those ideas into how you're trying to implement things better, because 99% of the time, what DHS wants to do is so well-intentioned. And talking to folks who actually have to do it, that's where you have the disconnect. It's not that we all don't agree on the goal or where we're trying to go or taking care of people. It's the how we do it. We can do the right thing the wrong way. So if we can all help do the right thing the right way, like, I'm down. Sign me up. So
okay. No.
One caveat to that, I know this is a public meeting and there are requirements on FOIA. And so I want to make sure that if I need to still call Jody Ann or Bess or whoever, that I can still do that. If we are going to have that conversation in here, I mean, that is a thing that I think that I don't want to squelch our collaboration outside of this meeting if that ever needs to happen. And an offline conversation that helps us get to the right answer.
Only thing that would prevent you from talking to each other is if you couldn't vote via email. So I think you're fine to if we're presenting something to you for advice.
Just making sure.
Totally,
I don't know. I do a lot of FOIA stuff.
She's a lawyer too. Just ask her.
FOIA stresses me out.
So how about once I get this video and do the minutes and get that all in, I send out an email and be like, hey guys, this is what we're working on once I get approval. And what do you want to talk about?
So let us take back the idea of our rulemaking and what we're working on. There's a whole, as you know, big old process. So where does this fit in that whole big old process? I think is the main thing kind of running through my head right now that we need to think through. But I can see some value in what you're saying.
I just want to make sure this is going to be on minute. But I know we're talking about the possible future, policy changes and whatnot. But, even the existing system, such as Access Arkansas, I know Mary's not here today.
She's not.
Right. Maybe we can help. I know that I represent all the people who's going to use it, and we're encouraged to go through. That's the key, right? And then there's many ways that to be improved.
Mm-hmm. That is something we've used the Medicaid Client Voices Council a lot for. And in fact, she just went over a bunch of notice changes today.
Yeah.
That they really helped us, with a lot of feedback on what they liked, what they didn't like. I think she walked through Access Arkansas's app with you guys at one point. And so yes, that's a great idea and something we have done with them extensively and could definitely.
Yes, and then, I've been talking to Mary about it, and then actually DCO is giving providers, the DDPA providers, a demo tomorrow. So the providers can help guardians and families set it up, pretty much we can do it for them, But I just wanted to make sure to talk about that.
We'll make sure Mary knows.
Elizabeth, whatever we can do to bring to y'all beforehand, because today we had a lot of discussion about what needed to go to the MAC versus what needed to go to you guys, if it will be helpful for us to bring those topics beforehand and then you decide where you need to vet them out to so we can prepare more details for the MAC. That way we can.
Sure.
If you want us to
I think the point of having your meeting first is so that you can kind of discuss and do that. So if there's something you want to take back to your group for further, discussion, that's fine. And I think part of what we want to do is the reverse too. So if there's something that you guys want to make sure that you get their input on, we're sending both ways.
Well, did they see our meeting from this morning? Will they see that?
The agenda, it's floating around here.
What Mary presented, is that
I don't know that it will. I don't know that we had planned to it. I think we could. It's a PowerPoint, so we can share it with you.
I know we meet on the same day, and I know it saves travel for everybody if we do that, but it's sometimes nice to kind of have that feedback from you guys. And I know we all too bring feedback from our members. Going back and saying, hey, this is what we talked about at this meeting. We all go back to our providers, and a lot of times, we all know enough to make us dangerous, and we need to go talk to the people actually doing the work to really understand what our thought is on a thing. So, being able to have the feedback from you guys in writing, or if there's something that we need to be doing is really, I think even just formal recommendations coming out, if they do on a biannual basis or something, every couple times a year would be great.
Well, I was just thinking about what Mary presented today for DDPA to look at that we worked on with you guys and for Anna's, for everybody to look at to see the changes that have been made.
Jason, can we get that slide deck out to them? We can do that. Jason said yes.
Anyone else want to?
I just think next week at DDPA you need to make a big announcement from them about the autism stuff so that everybody there knows it's a due process.
They are not all doing it, but we have
Okay. I would like to make sure everyone has signed their conflict of interest. Awesome. I think you guys are fine. If you could give them to me, and then I will make sure Stephanie gets that. So if no one else has anything, I will adjourn, and I will send out an email for next time, and we can communicate via email. And if we need to try to have a virtual meeting, that's something we can do. All right. Have a great day.